Now, moving on from musculoskeletal deficits, now we go into somatosensory deficits. Okay. Now, again, going back to the somatosensory cortex, or what somatosensory is, that's sensation such as light, touch, sensation, right? So, strong association between impaired somatosensation and recovery of motor function following CNS damage is 11 to 85%. Okay, so it plays a big role in your ability to recover or not to recover. So again, depending on how much damage to the somatosensory area, I mean, if you have 85% of your somatosensory area damage, you'd have difficulty with sensations, light, touch, temperature. That's going to make rehab very difficult. But if you only have 11%, then your outcome is different. So depending on how much is damaged, the problem with gauging how much is damaged is that somatosensory information is not stored in one area. It's like all over the brain, and it's hard to isolate. So that makes it difficult to gauge what percent they're really impaired. This 11 to 85% is really a guesstimate, right? Because there's no specific area of the brain that are saying, yes, you have 80% deficit. It's very, very difficult. Now, stroke-related impairments associated with significant loss of function. So again, going back to basic neuroanatomy, if you have damage to the primary somatosensory cortex, that means contra-lesional loss. So let's say you have damage to the right side, where you're going to get damage on the left side of loss of touch and proprioception. But you're not going to get any loss of temperature or pain. Okay, so that's a good quiz question. So if I have damage, a patient that has damage to the right primary somatosensory cortex, what can I expect on the left side? Well, they're only going to use light, touch, or proprioception. They're not going to have problems with temperature or pain. Now, if they have damage to somatosensory deficits, again, this is just a deficit, but let's say they have damage to the anterior parietal cortex. Well, then they're going to have difficulty with touch. They're going to have difficulty with vibration and joint position sense, and they're going to have difficulty with two-point discrimination. If I have damage to the posterior parietal cortex, they're going to have mild difficulty with simple tactile tasks. They're going to have profound difficulty with complex tactile recognition, and they're going to have difficulty shaping the hand to shape of an object. So if you get a patient that has damage to the posterior parietal cortex, and one of the rehab exercises you have is trying to do complex tactile recognition, well, heck, you're going to fail because they have damage to that area, right? But if you wanted to do a simple tactile task, then they should have no problem. So understanding where the lesion is and what you're trying to accomplish is important, right? So again, let's go back to the anterior parietal cortex. Let's say you have this patient that has damage to the anterior parietal cortex, and all you want them to do is exercise that it involves them having to discriminate 2 points. They're not going to do very well. Okay, so, and you're like, Patel, how do I know where the damage is? Well, again, you speak to the neurologist or you look in the report. A lot of times they will have a comprehensive report. You might have to dig a little bit for that information, but sometimes sitting back and taking your time and reading the medical history and looking at some of those reports will help guide your treatment. It takes a little bit more research on your side, but you owe it to the patient to do your due diligence and research. Now again, somatosensory deficits, patients with impaired two-point discrimination, they have poor recovery of the upper extremity dexterities. Patients with impaired proprioception will have poor recovery of functional upper extremity movement. Patients with combined impairment of light, touch, and proprioception, they have poor recovery of ADL function. So let's look at Janice and Jean. They have CVAs and impaired somatosensation. They have reduced light, touch, and two-point discrimination. So be careful when you're designing rehab for them that, hey, don't be so be careful with designing exercises that require light touch or 2-point discrimination because they have deficits there. Now, visual deficits, well, that will play a huge role, right? Disorders of the visual system vary according to location of the lesion. So example, if I have a patient that has damage to the right occipital lobe or the right parietal lobe, will produce visual field deficits. Left CVAs, no compromise to the visual field. So Janice and Jean both had a right CVA, a left CVA, so their vision is fine. They don't have deficits in the visual field. But if you have a patient that has damage to the right side, then their vision is affected. So see, not all strokes are the same. So that's probably great information for me to know that if I have a patient that had a right-sided stroke versus a left-sided stroke, and how much will the vision be affected. Okay, so this is good information. This is a great quiz question. Vestibular deficits, problems related to gaze stabilization, posture and balance, and vertigo or dizziness. Now, dizziness is used a lot by patients with brain injuries. They'll describe themselves as spinning, rocking, tilting, unsteadiness, lightheaded. But is dizziness a sign or a symptom? Yeah, since it's a symptom, how do you gauge? It's just somebody telling you that I'm dizzy. I can't do a test to measure how dizzy they are. So that makes it difficult to treat as well. Now, right hemisphere spatial deficits, inability to attend stimuli on contralesional egocentric space, meaning a lesion on the left, unable to attend stimuli on the right. All right? No. Usually if they have a lesion on the left, then they don't really have visual deficits. So disruption within the dorsal attention network. So the most common visual neglect that is egocentric means related to the body. Like they don't know where their body is in space. Okay. Now, right hemisphere non-spatial deficits impairs non-spatial functions, inability to reorient attention, attend to novel stimuli, maintain arousal and vigilance. They also have difficulty with target detection, slow reaction times. So you have to be more patient with somebody with right hemisphere non-spatial deficit. Now, let's talk about motor cortex and corticospinal tract impairments. You have motor paresis and weakness, which is the hallmark of lesions in the descending motor system. Measuring strength isometrically, isotonically, or isokinetically, you would do that with a manual muscle test. Before, people thought that strength training was not beneficial due to spasticity, but now they know that, hey, we can train patients with spasticity and they are getting results. We want to recruit paretic muscles. So what does paretic muscles mean? Basically, which ones are paralyzed or weak, right? So you can still use biofeedback or FES. So let me show you some examples of what biofeedback and FES is. And our treatment would be to improve strength, improve muscle strength, not function. Example, gait. Okay, so we're just, if they're weak, we're just trying to improve strength here. Now, motor cortex and corticospinal tract impairments, individualization and abnormal synergies, observation and description of resting posture, arm and leg, and we can use a very stroke-specific test, and we're going to learn about a lot of questionnaires and impairments, such as the Fugl-Meyer assessment, and Dr. Rose has actually developed another questionnaire for Fullerton, and we'll use those as well, so I'll try to teach you about all those. Now, spasticity, clinical scales and instrumented measures evaluate muscle tone. Treatment, pharmacological, surgical, and physical approaches. Improving strength in patient with descending motor system pathology not associated with increased spasticity. And we'll use the modified Ashworth scale, the MAS. So here it is. And let me show you this pendulum test here.